Hello, everyone. Welcome to our CalMap Primary Care Project Echo. It's wonderful to see you all here today. For those of you who don't know me, I'm Joanne Jung. I am a general pediatrician. I practice in San Francisco. Also serve as Senior Associate Director here at CalMap. And I'll let Laura Schumacher actually introduce herself also.
Dr. Lauren Schumacher. I'm one of the child and adolescent psychiatrists at CalMath, and I help staff the phone on Mondays and also help with CME programming such as the Echo.
I'll be introducing Charmi Patel in just a minute, but behind the scenes, actually, Anyanam, if you don't mind coming on camera just for a little bit so people get to see you. This is Anyanam. She is our extraordinary technical support organizer, general keeps us on track person. So I just wanted to let you know that this is who's behind the scenes here. And again, welcome to everybody. As you're coming in, go ahead and drop into the chat your name, kind of what county you're in, like where do you see patients, and as a grounding exercise today, it'd be wonderful to hear from you. What is one thing that you're grateful for today? And I'll just say mine out loud because I'm not going to have the chance to type it in. I am grateful that my son is coming home from college tomorrow. He'll be on a plane tomorrow to come home for the holidays. I'm super, super grateful for that. So if you can just share with us just something in the chat, like something that you're grateful for, along with your name and what county where you work in. And so I'll give everyone a moment to kind of start dropping some of that into the chat. Um, but as everybody is doing this, feel free to go ahead and take a couple of good deep breaths. Help us to get grounded here. We know how busy everyone is in the midst of seeing patients through a busy day. And we're so grateful that you're here. So take a few breaths just to ground yourself and let yourself know that you are really here. And with that, I will do a couple of quick introductions. We are talking about SSRIs in clinical practice today, and you can see here all of our names. Those of us who planned this activity are giving the talk, and none of us have any relevant disclosures of a financial nature today to share. Nothing, no potential financial conflicts of interest. You can see on this slide a quick note about who our funders are, for whom we are also very grateful. Our funders, both in the state government, California Department of Healthcare Services, as well as the federal government, the Health and HRSA, Health Resources and Services Administration. We are also very grateful for Dr. Charmi Patel Rao, who is our speaker for today. And she is a board certified child and adolescent and adult psychiatrist who trained at UC San Diego and at UCSF. She is the medical director at Vista Health Foundation, a nonprofit organization in San Diego that has multiple behavioral health and substance use treatment programs for youth and adults. She has developed an expertise in early childhood mental health and comorbidity between developmental delays and mental health. In pursuit of these interests, she had 11 years of direct clinical care experience in San Diego County System of Care. She was the supervising psychiatrist for juvenile forensics with the San Diego County Behavioral Health Care Services, Children, Youth, and Families for 2 years. She is also a health sciences assistant clinical professor for UC San Diego Department of Psychiatry and enjoys teaching medical students, psychiatry trainees, and hopefully as primary care providers here today. She is the lead chair of the Critical Issues in Child and Adolescent Mental Health Conference. With that, I will hand the virtual mic over to Dr. Patel Rao.
Sorry, I had to find where my mic button was. Apologies. I had to go back to the other screen for that. Okay. Thank you, Joanne, for that introduction and welcome everybody. So good to see people here from all over the state, primary care providers, as well as social workers and other members as well. So thank you all for being here. And we're going to spend the first part of our time together kind of reviewing some information about prescribing SSRIs. And then the second part of our time together will be talking about a case that hopefully one of you will bring. So as we're going through the slides, be thinking about if you have any cases where you've been prescribing or thinking about prescribing an SSRI for a patient. So, in terms of our learning objectives today, we're going to describe three commonly used SSRIs, including the usual initial and target dosing for those medications. Uh, Talk a little bit more detail about the risks when it comes to SSRI medications, common side effects, and the risk of activation, as well as the suicidal ideation black box warning, and then develop and apply language pearls for you all to be able to use with patients and families when discussing anticipated benefits, risks, and side effects. Yeah, okay. So I actually grabbed this from our CalMap website. I don't know if you all have been able to go look at the website and see some of the great resources that we have there. But we have a nice depression treatment algorithm, where it starts with, and we spent, I think, the last Echo and some other webinars talking about these in more detail, but talking about concerns for depression, how to assess for depression in terms of screening tools, how to conduct safety checks, and then kind of formulate the diagnostic picture for a particular patient. But then when we're thinking about treatment, this talks about, what to consider in terms of, are we thinking about starting with therapy as a recommendation, therapy and medication? And largely it's dependent on the level of impairment of the symptoms. So is it impairing the child or adolescent at home and at school? Are there concerns related to sleep disturbance, appetite suppression? Are there concerns related to suicidal ideation? Some of this can be captured using the PHQ-9 screening tool, but we wouldn't want to make the decision just based on that. But this kind of goes into if there's mild symptoms, we can think about psychoeducation support and monitoring with close follow-up and considering psychotherapy initially and then referring for SSRI if the symptoms don't improve or there's an increase in symptoms. When we're thinking about more moderate impairment of the symptoms, then we might be thinking about therapy at first, and then, if things, and with close monitoring, and if things are not improving, then thinking about SSRI treatment. And if things are more severe, we might want to think about starting with psychotherapy and SSRI treatment together. As you can see, therapy is an important part of this, right? We're always thinking about therapy as an intervention, and not, there could be some cases where we think just about medication as a starting point, but not typically. And then this algorithm would be very similar for anxiety as well. Okay. So when would you think about prescribing medication in the primary care setting, right? In an ideal situation, you would refer to a psychiatrist and that they would handle the prescribing. But we also know there's a widespread shortage, right, of child psychiatrists in particular, and so with limited or delayed access to psychiatrists for children and teens. And also, many teens and parents might be reluctant to seek help from mental health providers, and so would prefer to stay in their medical home, right? I mean, you've probably have patients that you've seen since they were born, and they feel comfortable in that place. So this, when there's situations where it's uncomplicated depression or anxiety that progresses to more moderate impairment, that might be a situation to consider in the PCP office. And as we said before, if there's a failed or partial response to therapy or other active support, that might be a situation to think about starting medication. Obviously, the parent and the patient have to agree. We're going to talk a little bit more about consent and assent in a little bit. There has to be, education on medication risks and benefits and potential side effects. And there has to be a plan to have close monitoring, especially in that initial titration stage of the medication, to make sure that there aren't any concerning side effects that are happening and assessing for benefit. And this is where CalMap can kind of be part of this, is having the ability to consult and collaborate when needed, right? So you have other providers in your network or in your practice that you can talk to about this, our resources on our website, but also, being able to have a place to go if something is not happening the way you expected it to in terms of the medication response. In terms of general principles, when we're thinking about prescribing medication, especially in younger kids, we want to start low and go slow. So the only sort of harm in starting too low and going too slow is that it takes longer to get to the benefit. But really, in younger children, and especially if there's co-occurring anxiety or sensory concerns or autistic individuals, this is really important, because what often could happen is um, there's a problematic side effect, and so the medication is stopped, and so then you're even more delayed in terms of getting to a point of benefit. And so, I know there's a kind of internal pressure sometimes that we feel. I want to get this patient to the right dose as quickly as possible, but it might be worth taking the extra couple of weeks to get to that beneficial dose just to by going a little bit slower. Part of the education for families is that there is limited FDA approval for some of these medications. Fluoxetine, escitalopram, and sertraline have some approvals in children and teens. But really, when these have been studied, there's some similar efficacy across the whole class of SSRIs. We typically start with those three just because there's more research on them and there is some FDA approvals. So I think as providers, we feel more comfortable. Families probably feel more comfortable with that. Of course, I think we all know that it can take up to 4 to 6 weeks. The key part of this is at a therapeutic dose to see improvement. So that starting dose, we're not expecting to see improvement. Sometimes people will report some improvement, and that's great, probably placebo, but there might be improvement from a low dose. And if that happens and it's adequate enough, we can stay at the lower dose. But really want to make sure that folks understand it does take some time to see improvement. These are not like the stimulant medications, which act really quickly. The other part that's important to remember is that if there's no improvement at a therapeutic dose, if we give it even 6 to 8 weeks, then that's a good time to consider changing medication, either to a different SSRI or a different class of medicines. And we'll talk about that in a little bit. The other thing that's important to keep in mind is to continue to titrate the dose, within the range, as tolerated if there is not a complete response yet, right? So if there's a partial response at a lower therapeutic dose, it is okay and probably good to increase the dose to a more therapeutic dose in hopes that we see a more complete response, right? If we're using the medication, we want to have a robust response to it, right? Obviously monitoring for tolerability. And in general, I mean, obviously, there's lots of studies that have shown that these medicines are helpful for depression and anxiety for teens and children. There's some research has shown greater benefit in anxiety disorders compared to depression for younger children. So that's something else to keep in mind as well. In terms of some kind of definitions to review, and I'm not going to read all of these to you, but just to make sure that we're kind of all thinking clear along the same lines, in terms of response, remission, recovery, relapse, and recurrence, right? So the goal is remission, and then leading into recovery, right? But it does happen in phases. I'm sorry, the acute phase of achieving response and ultimately full remission, and then continuing that. So we want to have that, including avoiding for 6 to 12 months, hopefully before thinking about if there's a place to taper off the medication. Yes, okay. In terms of studies that support the use of medication for treating depression, there's a few, and we'll talk through these in a little bit. Sorry about these acronyms on here, but wanted to fit everything on the slide without it being too busy. So the TAD study is the Treatment of Adolescents with Depression study, and it showed over 70% of people responded well to a combination of fluoxetine and CBT therapy, and that was compared to 60% for fluoxetine alone. And that was compared to about 40% for CBT alone and 30% for placebo. So it shows that the combination does work more effectively than either alone and definitely over placebo. The TORDIA study, the treatment for resistant depression and anxiety, looked at what to do if first treatment is not effective. And so, so switching to a different SSRI or venlafaxine, that's what the study did if there was no response to the first medication. And what it found was that adding therapy with the change into the other medication people had a higher response rate than just switching the medication alone. And so if therapy had not been started at the beginning, adding it in when you're making the medication change can be helpful. It did also show that early response to medication had a greater chance of remission, and that if somebody presented with symptoms like anhedonia, so reduced interest in activities, substance use, family conflict, they were less likely to remit. And so it highlighted the importance of assessing not responding early on and then changing or augmenting treatment as needed. Interestingly, this last one, the ADAPT study, the adolescent depression, antidepressant, and psychotherapy trial, sorry, uses the depression word twice, shows that when one looks at primary response measures that were used in that particular study, there really wasn't much of a difference between SSRI plus CBT and SSRI alone. And so, we always want to think about obviously including therapy as a referral, but what it means is if somebody is not interested in therapy or isn't going to follow up with the referrals for therapy, starting the medication could be helpful. Knowing that if they don't respond well to the first medication, then we're going to revisit the adding therapy in future conversations. So when thinking about, and I know this is kind of a busy slide with a lot of information, but in terms of thinking about choosing a specific medication, if there's a strong response to an SSRI in another family member, that's a good place to start. Even if we're talking about fluoxamine or citalopram, right? Not one of these kind of three that we mainly think about, because there can be some overlap in terms of pharmacokinetics and how family members respond to medication. But if that's not the case, then would recommend starting with fluoxetine, sertraline, or escitalopram. Most people have a favorite that they want to start with. Fluoxetine is nice if there's concern about medication adherence because it has a long half-life. But if a patient is on other medications, and you can check that on Hippocrates or another kind of drug interaction app, then it might be important to avoid it because it does have P450 2D6 inhibition. In that case, something like escitalopram or even sertraline could be a good option because there are fewer drug interactions with those medications. Let's see, the other things to keep in mind, like I said, fluoxetine has a longer half-life, and so can be helpful for if there's concerns. It can be more activating, so most people tolerate it best in the morning time, whereas the other two, sertraline and escitalopram, can be neutral, but if for some reason somebody feels tired or sleepy from it, then taking it at night is okay. The important thing is to take it at the same time every day. Okay. And then this chart talks about starting doses and titration for some of these medications, and then includes some of the FDA approvals as well. So for fluoxetine, would recommend starting with 5 milligrams if the child is under the age of 12, 10 milligrams if the child is over the age of 12. And a typical titration schedule for a child over 12 could be, 10 milligrams for 2 weeks, and then increasing to 20 milligrams for 4 to 6 weeks to assess response. If there's a partial response after that 4 to 6 weeks at 20 milligrams, considering to increase to 30 milligrams, and then and further as needed and tolerated. But if there isn't a partial response by 4 to 6 weeks at 20 milligrams, then would recommend switching to a different medication at that point rather than trying more or increasing higher. So for sertraline, similarly, starting dose could be 12.5 milligrams if the child's under 12 and 25 milligrams if they're over 12. And the titration schedule for over 12 could be 25 milligrams for 2 weeks, then increase to 50 milligrams for 4 to 6 weeks, and so on. And then similarly for escitalopram, and the starting dose would be 2.5 under 12 and 5 over 12. Just to give you a sense, there's obviously some nuance to how to do this. Some parents really want to go even slower than that. And so, you might be starting with, 5 milligrams of fluoxetine for a 14-year-old and going from to 10 to 15 to 20. These pills, the tablets can be broken in half. There's liquid forms and many of the options for many of these medications. And so there's no rhyme or reason to do it that way or not do it that way. But, this is kind of a generic titration schedule you can think about using. When we're thinking about starting medication, though, we have to, and obviously, go over some psychoeducation, have consent from the guardian, assent, so kind of it's okay to take the medication from the youth, making sure if there is a need for a safety plan that is discussed, and then have a plan for kind of a schedule of visits or check-ins about how they're doing with the medication. The psychoeducation is a really important part, right? And I won't kind of read all of these, but what's important is that it actually can reduce depressive symptoms on its own. There have been studies that have shown that even just talking about the psychoeducation piece can actually help somebody feel less depressed. And it's important to talk about, risks, benefits of treatment, but risks, benefits of not doing treatment as well, right? And what's going to be monitored if the family's not interested in treatment yet, what are we going to monitor to see if we need to think about it at some point?
I have a
Oops. Oh, thank you. Okay, it's important to know that for psychotropic medications, we have to document consent for treatment in the chart. And this can be a little bit different, I think, compared to non-psychotropic medications. It's also helpful, of course, to include the patient's assent for treatment in the chart as well. And if you're working with a foster youth, there will be county-specific processes for obtaining court consent for psychotropic medication. And that's important to think about as well. Okay, so in terms of side effects, I kind of group these, and this also is actually from our CalMap website, but I group them starting with the most common and mild side effects, and then we'll talk about the rare ones too. So it can be helpful to review these side effects that they're generally mild and time limited. So that you can help encourage patients to kind of push through and manage the symptoms. Like they don't have to just tolerate the headache if they have a headache. They can take medication to help them, but that it's time limited. So hopefully they'll manage the side effects and then continue the medication rather than stop the medication because it's problematic. And this includes GI upset, headache, fatigue, low energy. So of course, if there's some sleep-related side effects that are happening, then one thing that can be done is changing when they're taking the medication. So rather than in the morning, they can take it in the evening. And if they're feeling like it's hard to fall asleep, then taking it in the morning. That could be a nice way to try to see if they can resolve that side effect. Less common side effects, these can occur at less than 10%. And can usually be self-limited as well. So there's this kind of restlessness, activation, akathisia thing that can happen. And it's more common in kids compared to adults. It can happen with adults as well. But this can be a common reason why folks will stop medications because there's a concern that my symptoms are worse, right? If that internal restlessness feeling feels like anxiety, then that can be of concern. So one thing that can be helpful though is, and I had mentioned this in terms of talking about the starting dose, like starting at a lower dose and titrating even more slowly if you have concerns about this particular side effect. So in a younger child or somebody with autism or sensory concerns, even anxiety, it might be a good idea to think about doing that. In our older teens, it would be important to talk about sexual side effects and that the way to, if that does occur, the main thing to do is to switch to a different medication. So in terms of the rarer side effects, we'll talk about the black box warning in a little bit more detail. But even things like increase in appetite, the bleeding time, sometimes that comes up as a concern. That typically happens if there's other medications that are affecting that as well. Even the serotonin syndrome, it typically is not going to happen if it's just an SSRI, but if they're taking other medicines that can affect serotonin, then it can occur. And it's important to be monitoring for this because it does require emergency intervention, but very treatable. Medication has to be stopped right away, but very treatable. In terms of the black box warning, so this is something that I know can be very concerning for providers and for parents. And it was there to make aware that there's an increased rate in the spontaneous reporting of suicidal thoughts, and this happened in 2004 based on a study. But what is also important to share is that there's not an increase in suicides or suicide attempts. In fact, antidepressants reduce the risk of suicide and suicide attempts. What was found is that SSRI prescriptions for youth decreased by about a quarter after this black box warning came out. And as a result, there was an increase in suicides and suicide attempts in the US and actually across the world. There are several thoughts about the mechanism behind the increase in the spontaneous reporting of suicidal thoughts. One thought is that it might be related to this activation restlessness phenomenon that can happen because there can sometimes be an improvement in energy or this discomfort physical feeling before there's an improvement in depressed mood, right? And so that can sort of make somebody feel worse in terms of their mood. Another thought is that when a patient is taking antidepressant medicine, they're seeing a provider more frequently, especially if they're also in therapy. And so there's more chance to talk about those suicidal thoughts, right? It's asked of them more often, so there might be they might bring it up as well. I actually personally think it's a good idea or a good thing when a youth is sharing these thoughts. I get more worried when somebody has these suicidal thoughts and doesn't talk about them. And so I talk about that with families as well. So it's really important to tell families about the existence of the black box warning, but also that there's evidence that not treating depression can carry its own risks, especially when it's related to suicide. Reassure families that in most cases, there's no increased risk of suicidal thinking or behavior. And making sure you have a good plan for kind of checking in about side effects and concerns, that the family has that within the family, and then you have that with them as well. One thing that has been shown also is that the highest risk is in those first kind of week to 2 weeks. And then if there's a dose that's higher, a starting dose that's higher than usual. So again, I'm going to bring home the point again about starting low and going slow. And then we talked, I think, already about the serotonin syndrome, but in terms of these are the symptoms that you'd be watching out for. And if there is a concern, the safe thing to do is stop the medication and get them referred for emergency services. There are medicines and IV hydration that can help with this. In terms of monitoring, it's really important, and I know it's challenging in a primary care setting, so we have to be creative about this. It may not be in office appointments every week or every 2 weeks, right? It might be a quick phone check-in or messaging, via the messaging system, checking in with the nurse in your office, things like that. But it's really important in that first month, when you're titrating the dose, we're not necessarily expecting improvement in symptoms, but we are paying attention to possible side effects. And so that's why it's important to have the frequent follow-up. And then that can be spaced out as you get to the second month and further on beyond that. We also talked a little bit about activation. This can include things like irritability, that physical restlessness, disinhibition, manic appearing symptoms, self-harm. In terms of the kind of comparing it to bipolar switching is less common than behavioral activation with antidepressants. That was another worry I think that we all had. It was about prescribing these medicines and am I going to make my patient develop bipolar disorder? Antidepressants can unveil bipolar disorder if somebody was already at risk of developing it, right? It's not going to, quote, cause the bipolar disorder. Behavioral activation can happen initially in the initial days to weeks, and really it's when the doses are being increased. And with that, the mood doesn't change, right? It's these more like physical symptoms that are happening or behavioral changes that are happening. And it's not indicative of a bipolar disorder diagnosis by any means. Bipolar switching is more likely to happen later in treatment. and may not, and probably wouldn't stop if once the SSRI is stopped, right? There are mood changes, right? It switches from depressed, irritable moods to more like grandiose, manic, elevated mood. And like I said, much less common than activation. And this is one of those situations where probably it's helpful for them to see a psychiatrist, and then they might need to be on a different kind of medication, like a mood stabilizer instead. We talked a little bit about some of this in terms of, one of the things that might come up is parents might have concerns that their child might change their personality. They might be more like a zombie. And it's important to address this, right? Not just try to say, no, 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 that can't happen. But just, this is part of the reason why we start slow and go slow. We want to make sure that the medicine is helping, it's not causing problems. But sometimes at higher doses, there can be some kind of flattening of affect or apathy. And so that might mean that's not the right medicine or it's too high of a dose, and so those things can be discussed and make sure it's okay. And then the second piece we kind of talked about already in terms of how to talk about the black box warning. I feel like this should probably be a separate talk, but if first treatment doesn't work, what do I do next? You want to make sure it's a long enough trial, a high enough dose. You might then, if that's the case, you might want to switch to a different SSRI or switch to a different class, and then adding therapy if they're not already doing that is going to be important. But if we are thinking about cross tapering, probably the safest, most conservative way to do this is to kind of go down on one medication while adding in the new medicine. And this chart kind of talks about the dose equivalence of that. And so that's the easiest way to do it. But it can be done relatively quickly over the course of a couple of weeks because these medicines are all working on the same system, right? There can be, I'm sorry, I'm rushing a little bit because I want to make sure we get to the case time. There can be some discontinuation symptoms that can occur. These are not dangerous, but it's important to be aware of them. More likely to happen for medications that have a shorter half-life, like paroxetine or venlafaxine, but can occur with any of them if the medicine stopped kind of abruptly. And then the last thing, this actually came up when I was doing a session with one of the child psychiatry fellows here at UCSD, because she said, I always hear about, we should continue medicine for 6 to 12 months after symptoms improve, just to make sure they don't have any recurrence and things like that. But how do you then taper off? What do you do? And so I'm going to make sure we talk about that a little bit. So really how I do it is I decrease by about a quarter, obviously making sure the medication matches up every 1 to 2 months and assess how they're doing. You want to pick a period of time when things are relatively stable, right? Not before a big test or the start of school or something like that. But that's kind of a safe, conservative way of doing that, once they've had a period of remission. And then these are some of the references, and I'm going to hand it off back to Joanne. Just 2 minutes late.
Not at all. That was fantastic. Thank you so much. Just a great talk. I wanted to see, first of all, if there are any quick questions for our speaker on anything that she covered so far. So does anybody have any questions? I'd also like to encourage everybody for this kind of more audience participation part of things. Go ahead if you can, come onto camera so we can see each other, because I know that we're all coming in from different parts of California. It'd be wonderful to actually see each other here, kind of like it's virtual brown bag lunchtime. And we do not mind if you're eating. This is fine because this is the lunch hour. So either if you have any questions, okay, great. If we have concerns for waking, which SSRI would you recommend? Any pearls there?
I would say, and this is primarily anecdotal because I don't think in terms of the research, any of them are more or less likely to cause it. Actually, I should say paroxetine is probably more likely to cause weight gain, so maybe avoiding paroxetine. I have seen among those three that we talked about, fluoxetine, sertraline, and escitalopram, I've seen more weight gain with sertraline than with the other two. And so I would say, probably fluoxetine or escitalopram would be a better choice for that. If they do have weight gain, though, from an SSRI, and you're thinking about something else, particularly for depression, bupropion might be a good option because it doesn't have any concerns about weight gain. So,
Thank you.
good question.
Not seeing, okay, any recommendations about working with mental health clinicians providing services, coordinating care?
That's a great question because you're both very busy. And
Yes.
so, I mean, I think, obviously you have to have release of information to be able to do that. Uh, I think the best thing to do is to try to
Mhm.
schedule a time to talk and be very specific about, what is helpful in terms of the conversation. I think sometimes families are good at relaying information between the therapist and the prescriber, but some families are not. And so, having that direct communication can be really helpful, especially if you're seeing something in your office that might be important therapeutically to pass on. I think sometimes we get creative about emailing, and just as long as we're not providing, identifying information, that sometimes can be a nice way to be able to communicate as well. I don't know if others have thoughts about that.
Yeah, I'd also like to welcome others here if you found something that works and that really helps to improve collaboration. And this is where I think having integrated behavioral health staff in your as part of your primary care team can be super helpful. Um, this is actually about an ADHD med, but can ADHD meds like Vyvanse trigger panic attacks? Is this something that you've seen?
Yes, technically, yes, it can. But it's not uncommon to see ADHD and depression together, or ADHD and anxiety together. And so, depending on the level of impairment from those different symptoms and diagnoses, you want to think about treatment, and you wouldn't necessarily not treat the ADHD because you're worried about that. But if you have a patient who's newly on Vyvanse or an ADHD medication and they develop panic
Mhm.
type symptoms, it's something to think about. Does this mean we need to change the medicine, or was there an underlying anxiety as well that we also need to be treating?
Great. Another question to come in about the use of Luvox or fluvoxamine for OCD.
And that one, it's interesting because and I don't know if it's because there were more studies done on it or what, but even in my training, I learned that is sometimes a better SSRI compared to others. But that isn't, I don't think that necessarily pans out in terms of actual treatment. Other
Mhm.
SSRIs can be helpful for OCD. The
Mhm.
important thing is that you sometimes need higher than kind of the typical dose range to treat
Mhm.
OCD. So, for example, fluoxetine, we might see doses up to 80 milligrams,
Wow.
potentially for treating OCD. Obviously it takes some time to get to that dose, but sometimes
Mhm.
those higher doses are more helpful for OCD.
Great. Last question before we move on to cases. Okay. How would you know if the medicine is affecting sexual development? If the client has been on it for a long time, and here they are at 10 to 14, right?
Meaning like the Tanner stages development, is that what we're talking about? Not that sounds like a different question than side effects.
Um,
I
I would
don't know.
encourage Tina Page if you want to come off mute and just share your actual question. Are you talking about pubertal development or actual sexual functioning in an early teen? Any of those questions, I guess, having to do with development.
Okay. I actually have not heard, and I don't know if anybody else on our team wants to answer it, that it affects puberty development or
Yeah,
delays development.
yeah.
No worries, Tina. So yeah, I hadn't heard that is the case. So, some other medications can stunt growth, for example,
Yeah,
like ADHD medications, but with the
yeah.
SSRIs, I hadn't.
I
I don't
think, yeah, I think I had seen in the popular press some concerns, especially in teens, about, of course, sexual dysfunction, but even at younger ages, is that actually going to affect their ability to experience like sexual pleasure, like later on, like if they've been on this for a long time. Some of those concerns have been raised, but I don't know if anybody here is aware of long-term studies that have actually looked at this. Yeah. So there's that piece in the New York Times I think some of us have read and seen.
Okay.
Okay.
Yeah, and I would say briefly, yeah, so I think somebody posted in the chat the New York Times article that raised
Yeah.
this concern, which is very helpful. And I think if
Mhm.
there's been a lot of sensational it's a little bit sensationalized and the catchy headlines as is often in the media. Um I think the takeaway point from like kind of the article is that there isn't data on it, is basically the question. So we don't have data that this is a concern, but also it was more that like we
Mhm.
know that teens are being put on SSRIs for anxiety and depression. We do know that these medications can have sexual side effects like difficulties with orgasming or decreased interest or libido. But we don't know kind of there really isn't data on whether this is a concern or not. It's also, I think, complicated because we also know that kind of untreated depression also can decrease libido and interfere with kind of both kind of sexual functioning and also development of kind of age appropriate social interactions and all of that as well. So I think at this point, there's not kind of a clear signal. It's more that this is an area that needs to be studied more. And I think, it underscores the importance of checking in on if teens are noticing sexual side effects with SSRIs. But I think also being mindful of that pro and con, because also undertreated or untreated depression and anxiety can also impair that as well.